So now it's my pleasure to welcome Dr. Michael Rutter and Dr. Douglas von Allmen. Dr. Rutter, it's a privilege to welcome you. He is a pediatric otolaryngologist and director of the Aerodigestive and Esophageal Center at Cincinnati Children's Hospital Medical Center. And he's a professor at the University of Cincinnati College of Medicine. Dr. Rutter is internationally known for his expertise in the management of pediatric aspiration, management of congenital tracheal stenosis, management of laryngeal clefts, management of adult airway disease, and continued progress in management of complex airway disease. He has presented extensively and authored over 150 peer-reviewed articles and over 50 book chapters. He also holds 4 patents. Dr. Douglas von Allmen is assistant professor in the Division of Pediatric Otolaryngology at Cincinnati Children's Hospital Medical Center and the University of Cincinnati Academic Health Center. He joined that faculty in 2021 after completing residency requirements and fellowship in Cincinnati. Dr. von Allmen participates in the Aerodigestive Multidisciplinary Center as well as the Complex Obstructive Sleep Apnea Center. His interests include airway and esophageal reconstruction, tracheomalacia, and tracheoesophageal fistula. Thank you both for being with us, and one of our board members would like to share something with you.
Sure. Nice to see you.
Hi, everyone. I'm Steve Chesser. I'm an MPS dad, and I'm on the board of directors. I met Dr. von Allmen in December of 2024 at the Disney conference, where he gave a presentation similar to what he's going to talk about today, airway issues with MPS patients. My son had a severe case of tracheomalacia, a collapsing airway, which put him in the hospital 6 times in 18 months. I approached Dr. von Allmen after his presentation and asked if he would be willing to consult in my son's case. My son had a very competent battery of doctors, but I thought maybe a second opinion might be helpful. Dr. von Allmen agreed without hesitation. My son was evaluated at Cincinnati Children's in October 2025, and Dr. von Allmen outlined a course of treatment that he planned for him. We took him back to Cincinnati in January of 2026, and he was there for almost a month. Dr. von Allmen did 2 surgeries, the second of which was ultimately successful. He inserted a T-tube in his trachea, and now my son can breathe. He has a lot of concerns, as most MPS adults do, but his next breath is not one of them. I mention this because for 2 reasons. One, I want to thank Dr. von Allmen for his generosity in treating my son, and also to emphasize the point that the presentations that we give you here in this conference can be incredibly relevant to you. It certainly was to me and my family. We prayed for a miracle, and Dr. von Allmen provided it. Thank you, Doctor.
Thank you so much. It's so good to see you. Yeah. All right. Well, thank you very much for that very generous introduction. I'm here with my counterpart, Dr. Mike Rutter, and we're going to talk a little bit about complex airway management in our MPS population. These are Dr. Rutter's disclosures, and we both use products off-label. We're going to cover a couple different topics here, basically outlining different levels of obstruction, and then we're going to go through a couple cases just to show you some of the patient presentations and things that we've gone through in the past with some of our MPS patients. So this slide, really the big takeaway is that many of these patients have multiple levels of obstruction, and so it's usually not just one simple thing that's going to change the course of their breathing. So when we talk about upper airway obstruction, and these are the things that we think about when we're talking about sleep apnea kind of symptoms. So starting at the nose, you can have obstruction in the nose with the septal deviation, inferior turbinate hypertrophy. The tonsils and adenoids are one of the first things that we usually look to address in patients who have sleep apnea. And then as we go further down towards the voice box, the tongue base, the pharyngeal walls can be collapsible and contribute to some of the obstruction that we see as well. And so how do we look into these things? Well, first of all, the noises that people make can give us some indications as to where the problem lies, right? So snoring, stertorous breathing, which is kind of like a snoring noise when you're awake, tends to be more upper airway obstruction, as opposed to a stridor noise, which tends to be at the level of the voice box or below. And so for patients, it's really important getting physical exams. We use x-rays to look at the size of the adenoid tissue, and then doing some awake scopes through the nose, looking at the upper airway through the back of the nasopharynx and looking at the larynx to look for other areas of obstruction. And then obviously sleep studies can be really important in diagnosing and characterizing the severity of sleep apnea that patients can have. We talked a lot about this quite a bit in the past, but I just want to reiterate and emphasize that even minor procedures are major procedures, and our patients with MPS, they require extreme vigilance, and having an airway plan is incredibly important. Those periods of time of induction and emergence from anesthesia are really vital time points where we need to be paying attention. So brought up the colleague from anesthesia, just talked about a little bit about our airway team, but that incorporates anesthesia, our pulmonary colleagues, as well as us as ENT surgeons. Some of the things that are really important for you to know about your loved one with MPS is, how can their airway be managed, right? Can they be maskable? Does an LMA work for them? Can you see their airway with a traditional direct laryngoscopy, or does a video laryngoscopy need to be used? And then obviously, do they need to be flexibly fiber optically intubated? These are all critical things to provide to anesthesia providers who may not be as familiar. So when we talk about management of upper airway obstruction, like I mentioned, tonsillectomy and adenoidectomy is one of our first go-tos in terms of managing sleep apnea. This was a paper that looked at some of the outcomes there, and just what's important to know is that our outcomes of tonsillectomy and adenoidectomy are not quite as good as in the general population, and so that's just something to be aware of. And then also, we see really frequent adenoid regrowth. So if you start to get improvement in things and then hear some snoring creeping back in, that's something that you want to look at to see if that's becoming a problem again. Obstruction at the level of the larynx is also pretty common. That's basically due usually to redundancy of that mucosa in the voice box, and that can prolapse in and cause obstruction of the opening to where the vocal cords are. And that's typically a cause of some of the stridor noise that you can hear there. When we treat laryngomalacia, we typically do that by doing a procedure called a supraglottoplasty, and that's where we divide the fold that joins the epiglottis to the back of the voice box, or the arytenoids, that you can see there in the picture on the right there. But in order to do that, we use rigid instrumentation for that. So you need to be able to get direct line of sight to the voice box, and that's not always manageable in our MPS patients. This is another video that just is a flexible laryngoscopy that's being performed by one of our pulmonary doctors, and this is the voice box, and they're looking for the vocal cords, and this can just give you an idea of how obstructed and collapsible some of that tissue can be in some of our patients. This patient thankfully did have a trach that maintained a safe airway for them, But you can see finally as they start to kind of get through that, you can start to see vocal cords in the background. But as you can imagine in an emergent situation, these are the kinds of things that can create problems and why it's so important to have a preoperative airway plan. As we move down to talk about the trachea, so tracheal stenosis is a common term that gets distributed out there or used. I think what's really important here is defining what is the cause of that stenosis, and is it scarring that's actually narrowing the lumen of the airway, or is there a change in the structural framework of that cartilage that's causing obstruction? And the latter is common problem that we see in our MPS patients. We can treat stenosis in a variety of different ways. From an endoscopic perspective, we can, if it is scarring, we can use balloon dilation. We can sometimes lyse those scar bands using some instrumentation. Sometimes we use stents to help keep that area open. When we're talking more about a structural change in the framework, we have to shift our perspective in terms of changing that actual cartilage structure there. And that can be either removing the damaged cartilage or changing it and augmenting it with other grafting tissue like rib grafts. And then there's the use of trach tubes and T-tubes, which are a very real and important tool that we have to help treat airway stenosis and obstruction. So the other important piece with this is that it's not just about the trachea and the airway, it's also about the other surrounding structures. So this was a paper that was looking, you can see all the different conformations of the trachea there that are, let me see if I can use my pointer, there we go. So this is the airway up here, and you can see all these different conformations where the airway does not look the normal caliber. But what's important too is also those surrounding structures. So is there a blood vessel that's crossing over the trachea causing compression? What's the relationship of the spine and the sternum? Because those play a big role in how we think about treating stenosis. Many of you have probably heard the terms tracheomalacia, bronchomalacia. That is a term that's used for collapsibility of that tracheal wall, and particularly that's on expiration where we see that trachea back wall bow in. And one of the treatments that's used for this is what's called a posterior tracheopexy, where the back wall of the trachea is actually pulled back to the spine. And this is a little diagram that you can see here. That's done by our pediatric surgery colleagues. And that's something that we occasionally use in our MPS population. But the important thing to know about that is assessing the candidacy and some of the relationship of those surrounding structures, right? So this is a representative CT image, and you can see this is the airway coming down, but you can see how close that already is to the spine. So there's not really a whole lot of room to pull that back wall of the trachea backwards to help open it up. And so just again to emphasize, these relationships are really important when we think about the setting patients up for success for surgery. The other important piece of this is that our MPS patients tend to have a little bit stiffer back wall too, which can sometimes also make it harder to pull that backwards. I'm going to talk about a reconstruction case of mine. This was a 19-year-old MPS 4A who came in with stridor. She was having difficulty walking a block without getting short of breath. She had some restrictive lung disease. She did not have a trach. And this was her CT scan. So you can see here, this is her sternum, and you can see how much this is pushing and blocking off the lumen of the airway there. And these are the other CT scans as we're going from proximal to distal in the airway, and you can see the change in the shape of the lumen of the airway as it gets further down to the level of the sternum. This was the initial bronchoscopy, and you can see here how obstructed that tracheal lumen is. Some of the movement is actually me pushing on the neck to identify where that is in space. And so she had about a 2.5 centimeter segment where her tracheal cartilage was deformed, causing that compression and obstruction. And so we talked about a couple different options for her, but we elected to resect that area that was obstructed. And so we did that, and in addition to that, to prevent things from getting worse again, we actually removed the top part of the sternum, or the manubrium, where it was pressing in to create enough room to bring the trachea together. Obviously, we did this with intraoperative neuromonitoring, and then this video here is a demonstration of the technique that we used, just a little bit shorter than what it's demonstrated here, but it's called a sliding tracheoplasty, where we essentially cut the airway and split the front and the back, and we pull it together, and that allows us to create a bigger lumen than what naturally exists by just sewing the two ends together. So post-operatively, this is what the airway looked like. So it's a little bit angry in there. It's inflamed. There was some excess, what we call granulation tissue from the healing that you can see us removing here. And then because there was a little bit of still an oblique shape there, and I was a little worried about her progressing to having some stenosis there, I elected to put a stent in for a little bit. And this was all done knowing that I was able to see her airway from above. So obviously, exposing the larynx and being able to use these rigid instruments allowed us to do that part. Becomes a little bit more tricky if you can't do that. And then this is the stent that was in place that we're manipulating here and pulling that up into position. And then as we pass the scope back in, you can see the change in the caliber of the airway there with that stent in place. Then we brought her back a couple months later, removed the stent, and things were looking pretty good in there. You can see that that's still pretty nice and open. There's a little bit of irritation around where the stent was, which is common. And then this is her a year later, and she is still symptom-free and doing quite well. So you can see it's still nice and open. So this next case was type 3. This was a patient who had been on BiPAP for some OSA at night, but then unfortunately got COVID and got sick and ended up in the hospital and was on BiPAP 24/7 and having a lot of trouble tolerating being on the BiPAP. This is his CT scan. So similarly, you can see the narrowed area between the sternum and the spine here to the point where the trachea is being pushed off to one side and the esophagus is pushed off to the other. And so we did a similar procedure where we removed the top part of the sternum to create more room in there, but because it was a longer segment, we elected to just put some sutures to try to pull the wall open a little bit. And we were able to get him a little bit more open, and he was able to be transferred back to his home institution after being roomed back to room air off the BiPAP. But unfortunately, he came back to the hospital and was having some ongoing recurrent issues with his upper airway obstruction, and eventually the family elected to place a trach. And that's like I said, an important tool. Can help patients recover from illness easier, can allow them to spend less time in the hospital. But one other important piece of this is, by removing part of the manubrium at the top and creating that more space in there, we were able to make the tracheostomy a little bit safer and avoid some of the problems that sometimes can come with that. So again, tracheostomy is a tool that we use in MPS. So as far as issues with tracheostomy tubes, because we're putting a round tube in a lumen that is not the same shape, we can sometimes run into issues. So whether that's the trach tube rubbing on the wall, creating erosions, creating granulation tissue. It's really important to surveil trachs with ongoing endoscopies to catch problems early before they become major issues. So we'll use sometimes some steroid drops down to treat granulation issues or buildup. But again, early intervention for this kind of thing is key. And the other important piece with this is that there's a tendency to think that we should put a big trach in there to push those walls out and stent them open. But the reality is that that tends to create more problems. So really, bigger trach is not oftentimes better. Usually smaller, longer tubes tend to work better and can avoid some of the other issues that we were mentioning. So in summary, upper airway obstruction plays a big role in how we treat patients. Not all airway stenosis is the same, so it's important to have a good understanding of, is there scarring, is there tracheopathy there from, that we need to think about that a little bit differently. And then tracheostomies can be really good solutions for airway problems, but obviously keeping track of them and making sure we're catching issues early on is important. And then obviously our multidisciplinary care and communication with our other providers is really important, and I can't stress that piece enough. But with that, I'll transition over to Dr. Rutter.
And thank you very much for the invite. I'm going to go completely off script at the moment. Sorry, Doug. And so I've got a few more slides over the next 14 minutes. I don't really care whether we get through them or not. I would like to acknowledge both Dr. King and Dr. White for sort of setting up this talk pretty well. And so for you or the members of your family with MPS, there are two airway considerations that matter. One is, do I have airway symptoms? Do I need something to help me breathe? That's the obvious one. The far more important one is that most of you are going to need operations on occasions. And you think the important person is the surgeon you choose, and that is absolutely incorrect. It is the anesthetic team you choose, because the default setting is, I am far worse to intubate than anyone suspected. And so anyone with MPS has a very difficult airway to intubate till proven otherwise. And that means having a team, be it an ENT surgeon, an anesthesiologist, a pulmonologist. At the end of the day, the person who intubates you doesn't matter in terms of, are they an anesthesiologist or an ENT surgeon or a pulmonologist? It's who's the best person to intubate. I am extremely good at intubating people. For many years, difficult MPS patients, I've been the person who got called to intubate them. And I'm doing that less often. And it's not that I've lost a skill set, it's that I now have people in my hospital who are better than I am. Our pulmonologists, we have 5 who do all of the FRACS bronchs, and they are phenomenal. I'm now usually there as the insurance policy. And so if they're having problems, then we're really having problems. But the key here is you want an anesthetic consult before you go into a surgery, because you may not think you have a problem and you don't want to discover it on induction. The most frightening anesthetic complication is can't intubate, can't ventilate. You put someone to sleep. If you're really unwise, you paralyze them, and then you can't move air, and bad things happen, even for the most trivial procedures. And so I think the key here is having a team approach. So I'm just going to go through some of the very basics fast. So MPS 1, from my standpoint, when you're born, you're fine, and you slowly get obstructed. Usually it's snoring that gives the game away. By the time you're having exercise problems, you've really got issues. So it's usually, you don't know, it's the people around you, it's your family at night, you're snoring worse and worse. We know that when we evaluate you in an operating room, you will be harder to intubate than anyone expected from looking at you from the outside. That's just the way it is. And typically, what we're going to do is you're going to get a tonsillectomy and an adenoidectomy. You'll get a sleep study. You'll get another adenoidectomy. You'll get a sleep study again another year later. Basically, every time you deteriorate, we will work out where the problem is and address it. We might tackle your turbinates. We might do your adenoids a third time. We might have to take out tonsil tissue in the back of your tongue. Maybe one day you might need a tracheotomy. It's a progression with time. And a bone marrow transplant or enzymes for these things slow you down. They don't stop this happening. And so again, here's a same kid, 12 years apart, with a FRACS bronch. And while I know these images are enormously confusing, there's a lot of tissue in the way, and as you get older, it gets worse. This is the same child, age 21, FRACS bronch on the left. I'm doing a rigid bronch on the right. And what does the rigid bronch tell you? I haven't got a chance. I can't see anything. If I'm an anesthetist, because I'm using an anesthetic laryngoscope blade, I'm going, uh-oh, because that's not a good scenario. On the left, we finally found the voice box, and if need be, we can slide in a breathing tube over the flexible telescope. Some of these kids have a narrow nose. I can balloon dilate the nose to open up the road for pulmonology if I need to. MPS 2. If you thought the ones were bad, the twos are worse. And so a Hunter's tracheopathy tends to be worse in those with neurological involvement. And these kids may be desperately difficult to intubate, particularly if you weren't expecting it. They can be very challenging to place a tracheotomy. We had one young man sent to us who they'd tried to place a trach and couldn't. And I think we've actually got if we have time, I'll show you some of his pictures shortly. Here's a young man who needed he was walking, swimming. He's a very impressive young man, but his heart valves needed dealing with. And again, heart valves and MPS are not fun to operate on. So your cardiac operation is going to take longer, and you're going to be sicker afterwards. So you'll be intubated for longer, which means you'll have problems getting extubated. So then you get trached. And the tendency is, you're an adult, let's stick in a big tube. And then this happens. The tube is drilling through the back of the trachea. There's almost no room to breathe. And that's where the lungs come off down there, but 80% of that tube has drilled a hole in the back of the trachea. And so now has a trach, his heart's better, but he can't breathe and he can't talk. And so you customize to try and fit. You want a long tube, and all the tubes we use are round, and you're putting it into an area that's a sideways oval. So you can modify the tube a little bit to try and fit the anatomy. And this is putting in something called a T-tube. So T-tubes are not perfect, but they're often better than the alternatives. Talking, able to breathe, still has a hole in his neck. It's a compromise. MPS 6, this can be highly variable in presentation, as you know, and again, may be very hard to intubate without much warning. And so this is a young lady that I was scoping for the first time about a week ago. She's getting a heart valve. She only got diagnosed 6 months ago. And so she's never had any breathing problems, but as you can see, this is not a straightforward intubation. And in the end, I just plonk the tube in, but then we have to be sure we are all set for the extubation. This is not someone to extubate at midnight on a Saturday night. This is you want people around in case you have a problem and need to re-intubate. Meanwhile, I'm going to blow through this, and we've got 4 minutes. Let's just talk about some challenging cases. So this is a 19-year-old man who's at college, and he got the flu, and he was, running on fumes at that point. He had sleep apnea, though he didn't want to admit it. And he ended up on ECMO, which is never a great position to be. And this is a young man where they actually opened his neck and couldn't get a trach in. And again, I will show you why. So this is his initial flexible bronchoscopy. And he's got a very typical Hunter's trachea. And part of the reason why is that his sternum is almost touching his spine, and his clavicles are inside his sternum. That's his sternum, those are his clavicles. And so to put his trach in, we had to remove a little bit of the top of his sternum and the back of his clavicles, and then we could put the trach in. And he is still trach dependent. We ended up having to put some stents in his airway, and so he's now, he's been back at college for a while. I presume he's graduated now, but he has a trach. I'm not going to be able to get it out, but he's got a good quality of life. He can talk, he's functional, he can exercise, he's got a reasonable airway. And so I'll do one more case. This is a young man, and again, there's something to learn here. He's 16. He went in for PE tubes in his ears. That is the simplest operation that anyone can do. And he went in for what should take 5 minutes. And they lost his airway. And they trached him into his esophagus. And he came to us a month later with a 6.5 centimeter hole in his trachea connecting to his esophagus. It is the biggest tracheoesophageal fistula I have ever seen. And this is a disastrously awful airway. And that yellow thing you're seeing is a nasogastric tube. When we scoped him, we discovered that the nasogastric tube went through his nose, through his vocal cords, into the hole, and then to his stomach. It's not meant to work like that. And so, very big hole. You're never going to be able to stent something like that. So we actually created an operation for him where we disconnected his trachea from his larynx, peeled it off his esophagus, sewed up his esophagus, sewed up the back of his trachea, put in the tibial periosteum from his leg between the layers, and reconnected it to his larynx. And again, part of shared decision making. What did he want? We had a long chat to his family, and I said, you know, we are never going to get this trach out. And they said what he wants is that he wants to be able to drink Mountain Dew and eat pizza. And we achieved that. And so this is, after his repair, I saw him about a month ago, having not seen him for 5 years, and he has a trach. I can't do better than that. But he's eating Mountain Dew, he's drinking Mountain Dew, eating pizza, and he's got a safe airway. And so, you know, I'll take that. And so on bronchoscopy and MPS, the airway is always worse than you think it's going to be. Everyone with MPS should be considered a difficult airway till proven otherwise. And you need to go in with a plan A, a plan B, and at least a plan C, and possibly a plan D or beyond for making sure you've got a safe airway. And while intubation is challenging, extubation can be just as high a risk. And if you have to place a trach, as a general rule of thumb, long and skinny is better than short and fat. And it's a team sport, and that's really critical. Don't treat the problem, treat the patient. Don't think, oh, there's a heart valve, let's fix it. Think about, here's a heart valve in someone with MPS. Let's make sure we've got everyone on board. And so diagnosis and management with collaboration built on mutual respect. And just so you know, there are actually 2 papers in progress at the moment on MPS 2 and 4A. So we'll do questions after the next speaker, I think. So thank you very much.